Healthcare is too expensive. Employers are offsetting costs onto their employees. Who will make health benefits affordable for hard-working Americans and their families?
You will! This is the Empowering Plans Podcast, a show dedicated to helping you once again emphasize the benefits in your benefit plan. Now prepare to learn,
Plan,
save,
and protect with the FAEA Group.
Welcome to another episode of our Empowering Plans Podcast. Today, I am Jen McCormick, joined here with Bryan Dunton, another attorney at the FAEA Group, to talk with you about a critical, important topic. And Bryan, you want to say hi first and introduce yourself? This is your first opportunity to be on a podcast. So before I share the topic that we're going to be covering today, you want to introduce yourself and say hello for the first time. We're excited to have you join us.
Yeah, hi, everyone listening out there in the great void. It's great to be here today. It's great to finally get into one of these podcasts. It's a real good opportunity to get some of this important information out to everyone in a really timely manner.
Yes, thank you, Bryan. And today we're going to talk about mental health parity, and it was critical for you to join us today because on September 9th, the thing that you wanted to do when those regulations were released from the regulators, finalizing all of the different components of the mental health parity rule, I know that the first thing that you did was go to your computer and read all 536 pages. Isn't that right? Isn't that about right?
Yeah, that's right. I did read the entirety of it, and it took a long time.
So I am honored that you are able to join us today, an expert on this and understanding what we need to do, what we don't need to do, and what we still don't know what we need to do. So today we're going to talk through some of these regulations, the impact that they're going to have, because it's really going to be critical for us to unpack some of these components because there will be changes that plans and employers will need to implement for 2025 and make sure that they are prepared for when the second component of these rules go into effect in 2026. So briefly, Bryan, let's give a quick background about mental health parity, how we got here, how this is evolved. I know that this has been something that we've been talking through and working through for a number of years at this point, essentially since 1996, where the mental health parity statute went into effect and really put a spotlight on the fact that there was a disparity between medical, surgical, and mental health and substance use disorder at that time, really focusing on mental health. And through the time and over the years, we have really seen an evolution in 2008 where they really dug in and found that in addition to having lifetime issues that we didn't want to see plans, self-funded or fully insured, have any sort of restrictions or financial requirements, QTLs or NQTLs in place that would make it harder or more challenging for plan members or individuals to access mental health benefits. We saw some additional changes in 2021. And Bryan, I'll stop there. And why don't you tell us a little bit about how the changes from the Consolidated Appropriations Act of 2021 really had an important part of what you do and what we're able to do here at FAEA in just a couple words.
Sure. So the Consolidated Appropriations Act in 2021 began the requirement for health plans to perform an NQTL comparative analysis, and that's meant to demonstrate that the plan has written an operational parity under the Mental Health Parity Act. So that really changed a lot for me because it's become my primary focus here at FAEA, helping plans to ensure that they're offering benefits in parity with their medical surgical equivalents, expanding that access to care for their plan participants.
Thanks, Bryan. Yeah, and most recently, as we're circling back to what our discussion is going to focus on today, is the release of these finalized rules on September 9th. And a lot of this was in response to comments and feedback about that written requirement, because at that point up until 2021, there was always a requirement to comply with mental health parity. That wasn't a new component of the rule. The new component was really this documentation. And as we started out on this journey, it was really challenging to understand what it was that needed to be done in order to pass or to fail for the purposes of being compliant with the parity rules. So I think maybe the regulators were trying to give us a peek in how many comments, Bryan, were there that had been submitted that they needed to digest?
There were over 9,500 public comments that were submitted, which is pretty substantive. Most people don't end up deciding to spend the time to submit comments when there's proposed regulations on the board. So this was pretty noticeable.
Yeah, it just really goes to show that this is on everyone's mind. There is a crisis when it comes to mental health and making sure that there is the access and the abilities for individuals to take care of both their physical bodies and their mental bodies. So if we're taking these rules and we're trying to extract the three most important things from the rules for how it's going to apply to self-funded plans and getting ready for 2025, can you maybe help us understand what are your top three takeaways from these regulations? And maybe we can talk about each of those areas.
Yeah, so I think the big three takeaways are there's going to be a need for some plan language changes for a lot of plans out there. Along with that, there's plan fiduciary requirements that are going to be in effect with these final rules. And along with that, we can have a discussion later about fraud, abuse, and waste and how those are used as factors when designing and implementing NQTLs.
Great. So, I love talking about plan language. I think that it's something that we should always be focused on and not have our plan language set in place and forget it, but we should be coming back to the language, reviewing it and updating on an annual basis, and even more frequently as there are changes in regulations. So when it comes to some plan language changes, we are nearing Q4 and renewal time. So I think it is quite appropriate for us to dig into those a little bit more. So can you maybe share your thoughts and feedback about what we might need to start reviewing or changing or modifying in our plan documents as a result of these final rules?
Yeah, so I think in addition to just generally looking to make sure that the plan doesn't have any language that could cause parity issues from a mental health or substance use perspective, these regulations explicitly say that autism spectrum disorder and eating disorders are officially mental health conditions now. And they base that on generally recognized independent standards of current medical practice, which is a mouthful. So in our opinion, we don't recommend that plans define those types of conditions as anything else. Don't define them as medical surgical. It's going to be inconsistent with the law, and it's most definitely going to cause parity problems. Along with that, plans will, really importantly here, need to ensure that the limits or exclusions are no more stringent for medical surgical benefits for not only those diagnoses, but importantly, also for the services used to treat them. So that's going to be key to really comb through all your coverage language, all your exclusionary language, and make sure you don't have any of those types of limitations there.
Great, Brian. Yeah. And I remember reading something, and hopefully you can talk about this a little bit more. In the past, when we have worked on some of these reports, comparative analysis, I remember seeing that the standards and the protocols that some of the employers were using were based on state requirements. And that has always been a little bit of a challenging component when you have a state law that outlines the minimums or the baseline for which a plan must cover certain services, particularly mental health services. Maybe it's ABA services or other services where they have scope and duration requirements. Wasn't there something in the regulations too that was trying to address the state versus federal parity component and what plans should now be focused on, since states may be slower to remove those limitations that they have in place in their state mandates?
Yeah, that's a great point, Jen. Plans are no longer allowed to tie limitations to those existing state guidelines and say they're in parity. Regulators really wanted to move away from the differing standards that exist at the state level, which has at times really undercut the mission of parity under this federal law.
Yeah, and I think that that'll be something that we'll further need to dive into. So not only do we need to make those important changes, as you noted, to the plan documents to remove those limitations or ensure that there's nothing tying them to any sort of state requirements, it's possible that digging on that, we might need to also ensure that the underlying protocols that the networks or the utilization management team is using, that they're also not relying on those state mandate guidelines for how they're deciding whether something would or wouldn't be medically necessary. So there's a separate layer here too for us to consider. And the other thing too, I think that you had brought this up about stop loss. That's also something that could potentially be a concern here when we're working through the plan revisions and potentially modifying the limitations, removing the limitations to just ensure that there is that open communication as we're making these changes. Because some of these changes, Brian, are pretty critical to make. So even if the plan isn't renewing until March of 2025, these changes should be made for 1/1/2025. Isn't that true?
Yeah, that's correct. That's absolutely correct. Beginning of the year.
So there could be a potential gap prior to the plan's actual renewal where there may need to be a January 1 change to effectuate some of the requirements as part of these changes. So the other thing, Brian, that you had brought up was about plan fiduciary requirements. So I think we should spend a moment or two here. And some of our other webinars and discussions, we've really been trying to help everyone understand and show that there have been some cases, there's more litigation when it comes to a plan sponsor's fiduciary responsibility and ensuring that what they are doing is reasonable, that they have processes and they have protocols. And this is not only for ensuring that the cost of the drugs that they're paying in the Johnson & Johnson case or the Wells Fargo case, but also circumstances relating to the transparency rules under the No Surprises Act and the Consolidated Appropriations Act, that there are requirements for plan sponsors to ensure that they are doing their due diligence to ensure that there is the transparency, that there is not any sort of excessive fees that are being charged. Can you help us understand how, in addition to those other court cases and other federal statutes, that the mental health parity rules are bringing in some of those fiduciary components as well and really highlighting the critical importance of a plan sponsor?
Sure. So with these final rules, regulators have really taken a pretty proactive role here. They've stepped in and said that the fiduciaries now have to be much more involved in the entire process of performing an NQTL comparative analysis and ensuring that the plan's in compliance with mental health parity. Fiduciaries are going to be required to certify that they've engaged in a quote unquote prudent process to select a qualified provider, which here at the FIA Group, we are a qualified provider. We're an industry leader that provides NQTL comparative analysis testing, and we also provide support through our consulting services to ensure that provisions and or exclusions for mental health or substance use are offered in parity. The DOL stressed at a minimum that fiduciaries are now going to be required to review the comparative analysis once it's completed, ask questions about the results and discuss those results with whoever performed the analysis, and ensure that the results, the analysis itself rather, was conducted in a way that's compliant with the law. So they really don't want fiduciaries and plans to just get the comparative analysis and file it away on the shelf. They want them to have an active role in the process and really take charge to make sure that plans are offering benefits and parity.
It's a welcome change here, Brian, for this requirement to get some engagement and really create change, because it seems that that is the focus, that the plan sponsors and employers have seen this as a documentation requirement, and maybe the agencies haven't seen the type of change to access to the benefits and the care for the mental or the substance use disorder benefits that they were expecting to see. So it seems that it's possible that these requirements and these additional focus on this engagement in this process and ensuring that they are making these changes and they're going through this process and they have this additional level of involvement is to really help to ensure that we're not only documenting this, but we're also doing something to change it, to increase this access and to give some visibility to this really important issue.
Exactly right.
So the last thing that you had noted was talking about waste. Can you maybe give us an overview of how the waste discussion is important and how this plays into some changes that are going to be a little bit more complex? I think this might be the 2026 change, but something we should be thinking about now.
Right. Yeah, this is part of the final rules that won't go into effect. It's been delayed until 2026, but it's important to talk about now so the plan can start having that discussion with its vendors. So previously, plans and vendors were allowed to use fraud, abuse, and waste as factors when they design NQTLs. And factors are those triggering events, so to speak, that cause the NQTL to become active to limit or exclude benefits in any meaningful way. Plans can still do that for fraud and abuse, but now it's going to have to be tied to a generally recognized independent professional medical clinical standard, and it has to be reasonably designed. So they're trying to create a little more focus on this, so there's more critical thinking involved in plan design and the downstream effects that it'll have on participants. And along with that, they've removed the ability for waste to be listed as a standalone factor. They figure it's already baked into existing utilization management criteria typically, and leaving it as a standalone factor has allowed it to be a crutch, really, for certain plans or vendors so they could continue to administer otherwise impermissible NQTL. So this is all about offering benefits in parity and trying to eliminate those loopholes that exist.
Thanks, Bryan. Yeah, I think that those are really important things for us to take away. And of course, there's so much more in the over 500-page finalized rules that we have been presented with, but making sure if we're trying to summarize everything that we have discussed today as takeaways for plan sponsors and others in the industry to use in order to prepare for 2025, can you maybe give us those 3 points summarized so we know exactly what employers should be focused on for the fourth quarter?
Sure. So just to summarize, plans should review their plan language and make sure that they're not offering those benefits for mental health or substance use disorder conditions in a way that's more limiting than medical surgical ones. Certainly pay attention to anything for autism spectrum disorder, eating disorders, and any limitations on those. That's certainly a focus for regulators right now. Ensure that the plan fiduciary is involved in the process throughout in terms of having a comparative analysis done and the follow-up that happens afterwards, and start having those discussions with the plan's vendors that deal with the separate components of the plan, like utilization management. Start having the discussion about what factors it's using. Is it using fraud, abuse, and waste? If so, try and start having that conversation to move away from having waste in there and take that really proactive approach to this instead of risking waiting until an audit from the DOL comes down the pipe.
Thank you, Bryan. And on behalf of myself and Bryan, thank you so much for joining us today for another episode of our Empowering Plans podcast.